Okay, it seems to work. So first, Kevin and Velamir, thanks so much for inviting us. And I think we start in a classy way with just to introduce ourselves. My name is Guido Laps, and me and my friend and colleague Oliver Pütz, we are the founder and the head chiefs of the orthopaedic or of the Orthopädie am Gürzenich, right in the middle of Cologne. And our main competence is the conservative and the operative treatment in sport medicine. In my case, I'm a foot and ankle surgeon. Ollie?
Yeah, I've been a surgeon, and then I found out that my real passion is conservative sports orthopedics, and I'm taking care of the German national team in basketball, so I'm pretty excited about the day or the night. But I'm even more excited about the fact that we are keynote speakers concerning a topic where you guys are probably more experienced than we are. But caring is sharing, so probably can give you some input. And probably together he gives us a lot of input concerning EMG measuring. We want to show you in which cases we use EMG and Gait analysis.
Maybe just a few words to our brand new OAG campus, which is still in building process, unfortunately, but it works very well. It consists of different units and departments, and our center of analysis and individual training is the promotion lab with our team leader, Toby Mrotzek. Thanks so much, Toby. And you can say something more detailed in your workshop later on. Let's go ahead, Ollie.
And as you can see, so we are 4 doctors in our campus, and we are all taking care of high-performing athletes. Guido is taking care of Bayer Dormagen Handball, the basketball team of Germany, another colleague taking care of the German hockey team. So we're doing this since 15 years now, and so I think we have quite a lot of experience concerning surgical and non-surgical treatment of sport injuries in athletes. And so it was just a matter of time that we're going to start with using EMG as a tool for therapy.
So maybe first I can say a few words to my indication for the pedobarographie and also for the EMG of the lower extremity. So in general, for me as a foot and ankle surgeon, everything of biomechanical disorders, of foot deformities, of gait abnormalities, and most of all different gait patterns. And also we want to document the progresses before and after conservative treatment, before and after operation treatment, and also before and after an individual and sport-specific training. And right now we have a very objective criteria in our hand to judge at what time our athletes are fit concerning return to training, return to competition. And that are the indications for that.
So we're doing this now for about 3 years, and we found more and more indications for EMG analysis. So we are especially tendinopathies, Achilles tendon, patellar tendon, rotator cuff, return to sports, competition, practice, or in muscle injuries, ankle sprains, chronic instabilities of the ankle, insufficiency of the glutes, it's very common, especially in athletes, although they look pretty good in shape. Dynamic valgus of the knee, impingement of the shoulder, lower and upper back pain, and gait disorders, and as a tool before surgery and after surgery, and to get a good functional look at when they can be back on the court. So what we're going to talk about in special is ankle sprains, and Guido will tell you something about gait disorders and foot deformities in children and adults. So the fact that we treat handball players and basketball players leads to the situation that we are every day confronted with ankle sprains, and as you all know, ankle sprains are the most common injuries in handball and basketball in Germany, not just in Germany, especially in all other sports. We know that ankle sprains are a big problem. And as Nico said before, it's pretty important to know what is the mechanism of the trauma. And I don't tell you something new. I think that if you have a lateral ankle sprain, it's adduction, supination, plantar flex of the foot. But the main cause for the trauma and for the damage is the inversion moment and the joint velocity. So I don't know if you can see it behind. This is one of our basketball national players, and after a rebound, he just stopped on the foot of the defender and twisted his ankle and had a lateral ankle sprain. The discussion we always have is when to get them back on the court. And you all know it takes weeks until ligaments don't heal. After 3 weeks, collagen 3 promotes to collagen 1, which is more stiffer and stable. But when you see how the reality is, this is a research from the NBA, 4 seasons. They covered with about 800 ankle sprains, and 80% were lateral ankle sprains, and more than half were missing no games, and the other half were just missing 2 games in average. And if you know that there are 80 games per season, we're talking about a week that they are missing. That's just a recent review that says that it's approximately 15 days that you have a time loss when you have an ankle sprain. That's way out of being smart. So what is the problem in ligaments in most cases when they have re-injuries? Either they are elongated, scar tissue, or gone, so you don't have any kind of a proper stabilization of the ankle. So where's the catch? The problem is that we have a huge amount of re-injury within 1 year after trauma. More than 50% of all the athletes are still suffering pain or discomfort, and up to 40% are developing chronic instability of the ankle, which leads in 25% to severe arthritis of the ankle. So is there something that can help us if the lateral aspect of the ankle is totally damaged? And there's the peroneus muscle. That's the only muscle that gives us as kind of a seatbelt performing an inversion of the foot. So it decreases the inversion, so the mechanism of the trauma. And that's what we have. We have a pretty good protocol from the Berufsgenossenschaft, that's the insurance of the athletes in Germany. So it's very big. You have to do a lot of tests, white balance tests, figure 8, cohesion balance test. And the peroneal tendon or muscle is also addressed, but not in the activity, just in the power and the strength. And if you don't have an isokinetic measure possibility, it's pretty hard to know when the player is game ready. So, in my opinion, the EMG screening is the missing link to get them properly back on the floor, because we have no information about the muscle and muscle activity with the protocols we are dealing with. And it's pretty well known since years, and there's good science about it, that people suffering an ankle sprain have a decreased reaction time of the peroneal muscle. So there are deficits in the peroneal reaction time, so the seatbelt actually does not work. So we have to take care of the peroneal muscle. So this is a case report from one of our basketball players. He, unfortunately, 4 weeks before the European Championship, he suffered a re-injury of his ankle. He had a rupture of the AFL, CFL, a partial lesion of the deltoid ligament, and edema, classically, of the talus and the medial malleolus. You can see him here, it's a big guy. So, he had an ankle sprain 2 years ago, and since his first injury, he complained about discomfort, a slight pain during practice or during the matches, a lack of power concerning jumping and landing, he had a feeling of instability, what kept him from really performing in a well way. So what we do with people suffering an ankle sprain, especially with athletes, is we are taking care of the peroneal muscle. And Toby, so we work together. So the sporties, like Nico said, he's in charge for the screening. And then we found out some very, very interesting things.
So we did something like a test battery, which we do with every patient or every sports guy, which is including gait, which is including normal stance on one leg, which is including, do you perhaps know these blackboards? You can choose which part of your foot is stable, which part of your foot is moving. So we normally put it like this, that the forefoot part is moving, so we see the motion. We did it like here. You see it later in the video. It's more like bringing the patient in a supination position, and he has the task to put it in a flat position, his foot. And we saw him, was it 2 weeks after the injury?
4 weeks after.
Okay, sorry. And did all the test battery. You see as well that just for safety reasons, because it's the injury was not healed, he's holding himself. And this test was the most, with the biggest outcome concerning the peroneus longus muscle. So just play it again.
I don't know if you could see when he was on his left foot, the injured foot, he had to grab the handle to feel safe. When he did it on the right side, he even did not use the handle, so he was totally insecure. And that feeling he had for 2 years, for the whole time.
So just play it again, the video, so that you can see it. Or on this screen, perhaps it's easier to see when I'm away from the camera again. You see how slowly and insecure he's moving the ankle joint, and how uncomfortable he feels when getting in this position, and how easy it is for the other part, and how fast he can move out of the position and straighten the joint. And what was very interesting then to see, I gave him the peroneus longus and the peroneus brevis. We discussed it. Actually, the peroneus longus is too long to get to the peroneus brevis, but we can talk about this later. I named it peroneus up and low. And this is the left injured side. This is the right not injured side part. And you see that the upper part, or the peroneus longus, is the green one in this case. And here also the green one. And the difference between these two parts of this muscle is that on the injured side, there's a big difference in maximum, but also in the mean, in this motion to get to a straight position again. And on the other side, on the healthy side, these ones are I would say it is normal, it's the not injured leg, so there's no difference between these two muscles. And what was very interesting was then I tested it with a bandage, and the motion is pretty slow as well. Let's see, but better. So exactly the same testing protocol, so he feels more comfortable with this bandage. He also says he don't likes it and he don't want to wear it in a game. He likes tape more. Yeah, every national basketballer is taped, so he's used to. And that was the same day, 5 minutes later, with a bandage. And you see there's, like on the right side, upper to lower peroneus muscle, and there's no difference anymore. So it must be some kind of motion control, feeling secure, whatever. Yeah, so the task was how to get this muscle fixed, how to activate it the way it should.
So what we did then, or what Toby did then, was a biofeedback training so that he gets a feeling for his muscle. There's always a big discussion about the fact using orthotics while doing proprioceptive training. The problem is if you have a ruptured lateral ligament, there is no proper proprioception because the proprioceptors are gone. So still healing, still remodeling. So there is actually good science about it that if you are taped or if you take a sock or orthotics or a brace, that the idea is that because of the proprioception of the skin, the ankle knows where it is. So it seems to be a smart way to promote proprioceptive training.
So and this was 2 days after he had the task how to train the muscle, how to while our biofeedback training, while he sees this muscle activity, he got the feeling how to do it. And this was 2 days after without any brace, you see, and you see the velocity and the how he's moving, the motion control is way better. And I think on the next page you see also the data. This is 2 days after. It's just muscle mind and controlling, and there's no difference between the long one and the short one, which is even more interesting when this is the same muscle. The muscle fibers are working different in the upper and the lower part. This was just a test. Normally we just take the upper one, but this was very interesting to me. Yeah, and you said he's back to training.
Yeah, he's back to training, but the most important thing is you always get them back to practice. That's not the point, but he feels no more discomfort, no more pain, and he has a more stable feeling in his ankles. So I think what we are doing this every day now, that we are promoting the peroneal muscle to give the ankle a seatbelt and more stability, because it's known that after ankle sprains, the peroneal muscle does not activate the way he should. So that's just a suggestion. I think there will be more science in the future, but I think it's a pretty good tool to support our athletes to get them properly back on the court.
You're finished, okay. Then I'm going to present the next case, in which also the peroneus muscle plays a very, very important role. And I want to present you a case of a young 24-year-old man, a very, very ambitious badminton player. I think he played Landesliga, we call it in Germany. And he came to me for a second opinion with a typical lateral ankle instability of his right than his left foot. He had lots of supination trauma, let's say around about 2 or 3 times per week, which is really pretty much. And so at a first glance, if you see the case, you could say, okay, it's just another typical case of chronic lateral ankle instability of a guy in a stop-and-go sport, but no, it was not. And I really like that case because you can see so many things in only one case and one foot, because we were dealing with a very, in foot surgery, with a very, very interesting foot deformity. So I don't know if you can, no, you can't see it. I'm sorry about that. Maybe here at that screen, yeah. If you have a closer look to his anatomy and his physiognomy, most of all of his legs, can you see something eye-catching in your opinion? It's written already on the board, I see. So he has very strong upper legs, and he had pretty slim lower legs. And in combination with his foot deformity, he has a pronounced carbovarus foot, or he had it on both sides, right side more than the left side, with claw toes, a positive Service-Fragen test, shortened Achilles tendon, the lateral ankle instability. That was the main reason for him to come first to praxis. I decided to send him to a special neurologic department, and the result was he had a Charcot-Marie-Tooth disease. I don't know whether it's well known here. It's a very pretty rare neuromuscular disease. To explain it in very, very simple words, with a kind of muscle atrophy, and it's pretty often combined with the carbovarus feet. So as a foot surgeon, you will be confronted with these kind of disease pretty often per year. And let's just repeat some very short things about the carbovarus foot deformity. We have 3 up to 4 main features. So first of all, we have the excessive medial longitudinal arc. Can we drop down the light, or is it manual possible or not? Everything goes automatically. Okay, so we have the excessive medial longitudinal arc. We have the hindfoot varus. We have the forefoot adductus. Can you see it? And we also have the claw toes, which is here another patient than before. So we will pretty know how a normal distribution of the pressure in the foot of a normal foot. I think it's very hard to say what is a normal foot and what is a pathological foot, but we know very well how should it look like. Here the pedobarographic results. And we also know pretty well how it normally look like in carbovarus foot. It's pretty hard to say because we have so many different degrees of severity. We have so many different types of carbovarus feet. But I think you can see that doesn't look normal here on the left side in our case. What can we see here? We can see that we have a massive overload of the complete lateral foot, mainly in the area of the base and of the head of the 5th metatarsal. We have an overload of the first ray, which you can explain because the first ray in this foot deformity comes down. We have no really pressure in the area of the toes, not even at the great toe on the right side. And we know as well, pretty well, how the EMG results look like in patients with carbovarus feet. On the other hand, we don't have any official reference range of the activity of the peroneus muscle. But what we can see in his case is that the activity, and this is typical for that deformity, was pretty high. So let's see his Gait analysis. I hope you can see it. So if you describe it right now, you can see the first contact is not the heel. in the left and the right side. The first contact is the lateral forefoot, the base and the head of the fifth metatarsal. You see a massive hindfoot varus. Is it a separate video, the right? Yeah. You can see the claw toes and the contracted toes just to stabilize. So I think we all agree that's not a normal gait pattern. So just in a couple of words, in the operation we addressed the hindfoot varus, that's before and after the surgery. And we also correct the angle, the TMT angle it is called. So if you have a longitudinal line through the talus and you have a longitudinal line to the first ray, that's massive pathological. And you have the calcaneal pitch, which is the angle between the lower ground of the calcaneus and the floor. And after the operation, you see that the calcaneus comes down a bit, and that you have a straight line from the first ray to the longitudinal axis of the talus. So, what was the pedobarographic result after the surgery? You can see the right side, that was the operated foot. Now it's almost a hindfoot valgus, a slightly hindfoot valgus. That is 8 months after the surgery. I think the most impressive sign is from the side. You see that the toes are straight right now. And he doesn't need to contract to stabilize over the toes and the forefoot. Maybe you can show it again. And right now we have a plantigrade and orthograde foot pressure from the heel to the forefoot. And you can see this also here at the picture. So that is the left one before surgery, the right one after surgery. We can see that we have a heel presser again. And what is very, very interesting, we also see it on the left side. So that is a phenomenon you can see pretty often in that cases, that the non-operated side shows a kind of adaptation to that what we did on the right side in the operation. You see a better and a more general distribution of the forefoot here in contrast to the left side. And what you can also see is that we have a pressure at the area of the great toe. So another point which is very interesting, and it creates so many questions also for me, is that the activity, you remember, before the surgery, before the operation, was really pretty high. So was it pretty high? We have no reference ranges, we don't know it, but it was pretty high. Most of all in contrast to the result after surgery. You see the peroneus muscle here, the peroneus longus, had a pretty low activity. Is that good? Was that the result? To give that kind of result to a patient who comes and his only reason to come was lateral ankle instability. Yeah, it was. Because 1 year after trauma, and you can also see it here in the blackboard test, 1 year after trauma, he had no supination trauma at all, and subjectively he feels totally stable. Why is it like this? To objective this, one moment. Here is the blackboard exercise. That is the left side after the operation, the non-operated side. You can see a little bit of struggling. That's okay. A little bit more struggling. And in contrast to that, the operated side, the right side, after the operation, almost 1 year. Which is good. I would say a bit better than the other side. So also, while these exercises, which is pretty hard for a patient who had that anamnesis is also the activity, the middle range and also the maximum peak of the peroneus longus is much lower than before. So what we know is, in case of carbovarus feet, in each carbovarus feet you have a high activity of the peroneus muscle, which is pretty normal. Right now we have a very low, and he feels more stable than before. That is pretty interesting. Although we did nothing surgically at his ligaments. So just by correcting the deformity, you get these results. Now you have to look here at that screen. That is the heel raise test, and that is pretty amazing concerning the reaction of the toes. You see at the right side, the toes have a total fully contact to the floor. At the right side, no, at the left side, sorry. The left side is the not operated side, and the right one is the operated side. You can see it here you can see the claw toes is struggling, and on the other side, the toes have totally full contact to the floor and a better pressure distribution to the ground. And also in that case, you see the activity of the peroneus muscle was much lower than at the non-operated side and then before surgery. So the only thing I want to explain to you is not every supination trauma and not every unstable ankle is the same one. And in some cases it's not only an instability, and it's much more than this if you have some complex foot deformities. So thanks for your hearing, and I hope you get some interesting stuff for your daily business. Thanks so much.